Just want to welcome everyone to On the Air with phaware. I am Peter Leary. I'm a pulmonologist at the University of Washington here in sunny Seattle. Actually, I probably shouldn't say sunny Seattle, destroys my credibility right off the bat. Here in rainy Seattle, it's a fine, soft, wet day in Seattle. And I'm here today to really take your questions on just about anything that you want to ask me. I can't promise you that I have all the answers. But certainly happy to tell you things the way that I understand them. The one thing I'm probably not going to try and do is answer specific medical questions. So I'm going to try and keep things a little bit more general. This is something that Vic and Roham also did as well. This format's a little hard to get into the nitty-gritty and have those details to make really good pieces of medical advice. But I am more than happy to chat about kind of general recommendations and general advice regarding pulmonary hypertension. So let me see if there are any questions that are already up there, and if not, I can go forward. All right, so first question that we have on the stream is, what are some of the best ways that patients can prepare for each visit to you in clinic? So, I think it is so important when you think about pulmonary hypertension to really focus on follow-up and how can you get the most out of each of those clinic visits. And so what are the things that we're trying to figure out at a clinic visit? We're trying to figure out, one, has your pulmonary hypertension progressed? Has it gotten worse? Do we need to add more medications or increase the medications that you're already on? And so what are one of the key ways that we make that decision? So we do a lot of tests. We do 6-minute walk tests and echocardiograms, and we do blood tests, which are all tools in the tool bag to try and help us understand whether or not your pulmonary hypertension has progressed over time. But one of the best ways to know whether your pulmonary hypertension has progressed is how you're feeling. A patient is their own best early warning sign. And so what I typically tell patients is think about your good days. Everyone's going to have good days and bad days. And a bad day could be because the neighbor's dog was out barking and you didn't sleep and you didn't have dinner, or kind of any number of different things. It could be that you went out to dinner and there was a lot of salt. And now you're holding on to all that extra fluid and you're having a bad day. But if you notice that your good days are starting to slip, if you say, hey, you know what? Yesterday was a good day, but now I'm more short of breath on my good days than I was before, that is a warning sign to me and to most pulmonary hypertension providers that your disease might be getting worse, which might be the type of thing that, as long as everything is telling somewhat the same story, that we think about adding or increasing the medications that you're already on. So that's one thing that we're really going to be thinking about. A second thing that we're going to be thinking about at that visit and that you can prepare for. So the first thing you did was you thought about how you're doing on your good days, or whether you're having fewer good days on the whole. Second thing that we focus and spend a lot of time on is volume. And by that I mean, how much fluid are you drinking? How much are you taking in? Are you eating too much salt? We know that the heart is nothing fancier than a muscle. And if I was going to go, my patients have seen me do this exact thing before, and our nurse coordinator has probably heard it so many times it drives her nuts. But if I was going to go pick somebody up, I would never pick them up with my arms stretched out like this. I'm not very strong. I would come over here and I would pick them up here where I'm nice and strong. When the heart is carrying around, or you are carrying around a lot of extra fluid, your heart gets stretched out and it can't do its job very well. When you stay away from salt, when you stay away from fluid, when you take diuretics to make you pee out that extra fluid, your heart comes back to a position where it is stronger. And so one of the things that we're going to be talking about, and that you can come prepared and be ready to answer, is how do you think you've been doing in terms of getting rid of fluid? How do you think you've been doing at trying to do what we're hoping for in pulmonary hypertension, which is always to stay just a little bit dehydrated? or kind of right on the money, but not too much fluid. And the ways that we think about that are, have you been keeping track of your weights? Has your weight been going up? Has your weight been staying stable, but you really haven't been eating anything? The type of thing where we think maybe you're losing dry weight and holding on to extra fluid weight. Do you feel like your legs are puffier? And specifically, not just puffier, but if you push your finger into your shins, does it leave a dent? Is that dent more than it used to be? Are your pants fitting tighter? These are the types of things that we either should be asking you, or if you've noticed and come prepared to talk about it, we'll be sure not to miss because you bring it up. The other thing that we think about at a visit and a follow-up visit is, are you having side effects? So every drug is part cure, part poison. In my perfect world, we wouldn't have to use any of them. That said, we know in pulmonary arterial hypertension in particular that these drugs can be very helpful, but that doesn't mean they don't have side effects. And so we want to hear about those side effects for two reasons. One, we sometimes have tricks and techniques to either change the dose, or we have approaches to give you other medicines to kind of help with those side effects. And lastly, we want to make sure that people aren't blaming things on the drugs that aren't in fact side effects. You know, if somebody comes in with terrible crushing chest pain when they walk, the last thing that we want to do is short circuit that evaluation by saying, oh, that's a drug. And so we try and help triage those side effects to help people understand. And so when you're coming in, how are your good days doing? What are the things that kind of speak to whether you're holding on to too much fluid or not? What kind of side effects might you be having? And what other new symptoms might you be having that may or may not be related to pulmonary hypertension? And if you come in prepared to talk about those things, a lot of my patients who I've been seeing for a while will kind of rattle these things off at the beginning of their visit. And then we can focus on something else that they may want to spend time for. Or, you know, I'm human just like everybody else, and maybe I forget to ask some of those questions. But if people are ready and come ready to talk about those things, there's less of a chance that they'll get lost in the shuffle and missed. And that's true for whichever doctor you see. So let's see. Next up on the question list here is, what do you tell new patients the first time they come to a visit about this disease and treatment? So that's, you know, I'll tell you a little bit about it. And the reason why is that when I see a patient for the first time, this part of the conversation oftentimes takes half an hour, 45 minutes, an hour as they get to understand their disease. And understanding what's going to happen over time unfolds over time. And so all of this conversation can't be compressed into that first visit. But what I normally tell people is that pulmonary arterial hypertension is not a disease that you wake up on a Sunday morning and say, man, I really want to have that. It is not a great disease. We wish that it didn't exist. But at the same token, 20, 30 years ago, this was a disease that we didn't have any tools in the toolbox. This was a disease where it was progressive and fairly relentless. We are in a lot better place now. And a lot of times when people come to a pulmonary hypertension clinic, they have a view of pulmonary arterial hypertension from the early 1980s or from the early 1990s. Because the advances in this disease have occurred within the career of a lot of doctors. And so there is a good chance that doctors that patients have seen on their way to a pulmonary hypertension clinic have a much more gloom and doom sense of the disease than those of us who are actively treating patients with pulmonary arterial hypertension right now. And so it's still not a good disease to have. There's still a chance that it's progressed. It's going to be something that we're not going to cure, and that, like diabetes or other chronic diseases, we're going to continue to work on a month-to-month and year-to-year basis. But we do have a lot more tools in our toolbox. Now, people oftentimes will ask about, What is my prognosis? That very first visit, they'll say, what is my prognosis? And I think that is a great question. But each time I do a little hand waving because that very first visit, I don't have a great sense of people's prognosis. I can spit out numbers. We have numbers that kind of predict how patients are going to do 1, 3, and 5 years after that first visit. We have characteristics that tell us about people's risk, whether they're likely to do better or not do better. But one of the main characteristics that tells us how people are going to do over time is how they respond to our drugs for pulmonary hypertension. And once we know that, or have taken care of patients for a year and have a sense of the trajectory, kind of the pathway that their disease is on, then we can do a little bit of a better job of trying to kind of look into that crystal ball and predict the future. That said, I always like to remind people that it is just a crystal ball. We don't always have the best sense of what can happen. And one of the things about pulmonary hypertension is that it weakens your body's ability to fight other problems that come up. And so even if your pulmonary hypertension is doing pretty well, we think your disease is stable, there's a chance that you could get a pneumonia or something else that kind of comes in, and that by definition we can't predict because it's a second problem that can change things. And so it's hard when the future is a little bit uncertain. And we certainly don't want people to feel like the sand is always shifting under their feet, because we are able to tackle a whole heck of a lot more now than we used to be. But we also don't want to get people too much the sense that we know exactly what is going to happen at all times, because there are these other problems that come in. We've got a question here. What is my opinion on oral versus inhaled versus intravenous treatment? So I think about these all as different tools in the tool bag. And right now I'm going to make a shameless plug for research, which is to say, we don't, in the pulmonary hypertension community, have a lot of research to tell us whether one drug is better than another drug, whether one treatment is better than another treatment. We have good evidence to suggest that the drugs that we're using are pretty good. We have growing evidence to suggest that the drugs that we're using are good in combination, which is good because that's what we're already doing, but we're getting a lot more of that evidence to support that. We're not always great at knowing, is one going to be better than the other? So what I'm about to say is going to be something that doesn't have a lot of evidence behind it, but does kind of capture the belief that I have and that a lot in the community have. And that is that the IV or subcutaneous, which are both continuous ways of giving these prostacyclin analogs, are probably the most potent form of this drug that we have. So if you take a pill, the drug goes up in your bloodstream and then it comes down until you take the next pill, and then it goes up and down and up and down. And the same thing happens with inhaled, up and down, up and down. People tend to get side effects at the up part, and they get the benefit from all the amount that's in the middle where the medicine is. With a continuous drug like an IV or a subcutaneous infusion, it goes up and then tends to stay up, meaning that you can oftentimes give people more drug with fewer side effects than you could with some of the oral or the inhaled forms. And so at this point in time, many people's thought, and mine included certainly, is that the intravenous and the subcutaneous forms of these drugs are still probably the most powerful or the most potent. That said, like I said about the disease, most people don't wake up on a Sunday morning and say, man, what I really want to do is take a continuous infusion of a medicine. And so there's a lot of enthusiasm, a lot of optimism to say, oh, can I do the inhaled? Can I do the oral? And what I would say is, for patients that are very, very, very sick, my tendency and the guideline suggestion is that we start with the continuous intravenous forms of these medications. That said, for patients that are less sick, it may be appropriate, and what we oftentimes do is start with an oral form of a prostacyclin or start with an inhaled form of a prostacyclin, recognizing that there is a decent likelihood, and in fact, probably the majority of patients are going to go on to need a continuous infusion medication after that. There are some studies right now. There's the BEAT study looking at combinations of oral and inhaled prostacyclins to see whether we can smooth this out and kind of mimic a continuous infusion. And so we're participating in that study. It'll be interesting. I think we're all waiting to see what the results are, to see whether or not there is really a meaningful alternative for that kind of approach. In terms of oral and inhaled, I think of those medicines fairly similar. There's slightly different side effects that people tend to run into with those two forms. And so a lot of it is just kind of balancing the benefits and the side effects like we do with all of our drugs. Oh, here we go. I know every patient is different, but what is your standard protocol for treatment for patients that you see? So that is a good one, and that is a tricky one. And so this really does end up being a very personal conversation with your pulmonary hypertension doctor. I would say that all treatment plans start with the diagnosis. So pulmonary hypertension, high blood pressure in the lungs, is actually fairly common. Probably about 10% of all echocardiograms, 10 to 15% of all echocardiograms done at the University of Washington have pulmonary hypertension on the echocardiogram. That said, the minority of pulmonary hypertension is pulmonary arterial hypertension. And so before we start talking about all of these drugs, prostacyclins, endothelin receptor antagonists, sildenafil, tadalafil, it's important to know that we're starting from the right diagnosis. And so if you're not starting from the right diagnosis, then I think that you certainly run the risk of getting drugs that you don't need. You sometimes run the risk of getting drugs that are going to make you feel worse, either from the side effects or from the drug's action itself. And so before we start with a treatment plan, the biggest thing is making sure the diagnosis is correct. And oftentimes what that means is repeating a lot of tests that people have had elsewhere. And I know this is frustrating. But oftentimes at pulmonary hypertension centers on a right heart catheterization or some of those other tests, there are very specific things that we're looking for, that we're used to looking for on patients with pulmonary hypertension, that because pulmonary arterial hypertension is a rare disease, aren't always the focus when people are doing these tests and these procedures elsewhere. And so we oftentimes will repeat these tests as we kind of get to know somebody. Now, assuming that somebody is one of those 5% or so of people with pulmonary hypertension that has pulmonary arterial hypertension, then the treatment approach is largely based on the severity of the illness. If somebody is very, very sick, and this, I mean, shortness of breath at rest, passing out when they get up and walking around, we will oftentimes recommend starting with our biggest guns first, and that is those continuous infusion medicines, subcutaneous or intravenous. If somebody is a little bit less sick, historically we would have started with a single drug, sildenafil or tadalafil or macitentan. There are some patient selection features that go in, and then if they weren't doing well in a couple months, that we would add a second drug. There's been growing evidence that we might start with an upfront combination of drugs, perhaps tadalafil and ambrisentan. This was the results of the AMBITION study, suggesting that maybe more aggressive upfront treatment is useful. And so this is a conversation that we have with our patients, and a lot of it boils down to how sick they are, whether we start with one drug, whether we start with two drugs, or whether we start with a continuous infusion of a medicine. So lots of good questions coming in, and because I'm a chatter, and you can see I chat with my hands, I'm probably not keeping up with all the good ones that are there, but I have one here that says, do I recommend that patients keep journals? Yes, I do recommend that patients keep journals. Um, there's probably a couple styles of journals that are out there. There's just journaling about kind of your experience with this disease. So uh, I think that for some people, kind of writing down the trials and travesties and successes and setbacks is a good way to help process this disease. On one part, this is a disease of the body. Um, that said, any chronic disease also has a component where you can start to feel demoralized or beat up by the disease over time. And so finding an outlet that helps with that, ooh, that is big. It's not going to be journaling for everybody, but it is going to be for some people. Now, the other type of journal is a medical journal. And this, I think, is probably something that probably is good for just about everybody. Um, and normally, what I recommend that people write down is they write down how they're feeling that day, preferably in some kind of quantitative way, 1 to 10, whatever scale works for you, kind of putting in how they're feeling that day. How much they weigh, again, getting at the idea that holding on to extra fluid can explain a big part of how people are feeling on a day-to-day basis. And then, anything noteworthy, particularly if they're having a bad day, just a note about why. If they're having a great day, maybe a note about why. I exercised yesterday. I did a great job with my salt. I didn't add any salt to anything, and I drank less than 8 cups of water, and today I feel great. These are the types of things that, as you get to know your disease and yourself better, will help do what we can't do in clinic, which is take all the book learning, take all that other part, and translate it into a medical program that makes sense for you at home. And I'm happy to look at the journals when people come in and say, you know what I'm seeing right here? Your weight went way up, and it goes way up every weekend. Are you going out to Outback Steakhouse on Friday? Something like that, something that may kind of jump out at me when I look at them. And so I think a lot can be done with those kinds of medical journals. But I also I think it's important that people acknowledge that wrestling with this disease is hard, and finding an outlet like journaling for all of the kind of emotional pieces that go along with this disease is important as well. What do we have here? What do I wish every patient knew or understood when it comes to participating in trials? So, there are a couple things. Participating in trials is important. And I'm going to broaden that and say participating in research is important. And the reason why is that I've mentioned earlier when we were chatting here that there is an awful lot of progress that has happened in this field in a very short period of time. There is no way that progress could have happened without a vibrant community behind it. And when I say a vibrant community, what do I mean? I mean researchers, clinicians, and patients, and caregivers, all working together to try and make progress in this disease. We couldn't have made this much progress over this period of time if any of those pieces wasn't in place. And so, that said, I think on the one hand, you can look at the progress that's been made and say, oh, good job. Everyone's put in their part. We have a vibrant community. On the other hand, you can look at where we are right now and still see that there is a lot that needs to be done. There is still a lot of progress yet to be had. And the way that we are going to do that, the way that we are going to continue to make progress in this disease, is continuing to be a vibrant community, continuing to work together as a team to try and tackle this disease. And the ways that we think about doing that are observational research. So there are registries out there. The Pulmonary Hypertension Association has a registry that is for Centers for Comprehensive Care. There is a CTEF registry. Individual institutions have registries. And so what is a registry? A registry is where we look and take all that information that we're already getting on a routine basis. Sometimes we're just looking at routine clinical care. Other times we're adding things. So we're taking extra blood samples to look for research questions. And we're trying to understand trends that might appear. Now, these trends are sometimes causative, meaning if I wear a seatbelt, I'm less likely to die in a car crash. And sometimes they're just connections. The idea that if you wear a baseball hat, you're more likely to get hit in the head with a baseball probably reflects the idea that baseball players wear baseball hats and not that baseball hats cause you to get hit in the head with a baseball. If anything, it might help because it keeps the sun out of your eyes, blah, 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 blah. So observational research sometimes gets a bad rap because when we're looking for these patterns, researchers, myself included, can be misled by what we're seeing as we try and understand these patterns. But they are a really powerful tool because a trial is typically asking just one question. And it's typically about a drug or something that you're doing. Whereas these registries and observational research, you can ask tons of different questions. It may not give you the definitive answer, but it is a great way to try and move the field forward. Trials are the other piece. So trials, in some ways you have a little bit more skin in the game. You're trying out a drug that animal research and sometimes previous small trials have suggested might be a good idea. But the reason we're doing the trial is that we acknowledge that we don't know the right answer. We don't know definitively that this is going to be a drug that helps you, or whether there might be side effects that we haven't run into. And so that's a much more personal decision about whether to not to be involved. I can tell you that where we are today is because people 5 years ago, 10 years ago, 15 years ago, 20 years ago did trials. This is the way we know, this is the way that we answer questions in a much more definitive way than these observational trials. And particularly when we're talking about drugs, that's the kind of evidence we need so that when I look at you and talk to you as a patient, we can say, hey, there's good evidence for this. This is a drug that has side effects, it's got risks, but we think that on the whole, because of great trials, it's going to help you. And so I would say that those are the kind of the key points of trials that I hold in my head. When you're in a trial, it doesn't mean that your pulmonary hypertension doctor stops being your doctor. They're going to continue to make decisions and work with you to make decisions that are the best for you. It's not as though they suddenly become an arm of the trial and treat you as a number. They're always going to be your doctor. And so you can come out of a trial if you need to. There are lots of different ways. So I really encourage patients to participate in trials, but also to, if they're not kind of game for that, to participate in research. And there are lots of ways to do that. Oh, here we go. Here's a question that I can't answer for you. I am on sub-Q Remodulin and have allergies to tape. My doctor is discussing the implantable delivery. Do you know when it will be available to the general public in the United States? So I will say that we have a lot of patients that are eagerly awaiting this. I think that there's enthusiasm, there's excitement. We were not one of the centers that trialed this in the US, so I don't have any personal experience with the implantable pump, but I certainly have talked to many of the doctors who did participate. We keep thinking that we're almost there, and it keeps being pushed back. And a lot of it is the regulatory approval for some of the pieces involved in the implantable system. And so our hope is always soon. But I have gone away from giving my patients concrete dates. I've given them a couple times and have had to eat a little humble pie on the back end of that. So what I would say is keep asking the question. It's a good question. And I am also enthusiastic to see how it's going to work and when it rolls out. Oh, here we go. What do you wish doctors or ER nurses knew about this diagnosis, about this disease to help with earlier diagnosis? So earlier diagnosis is a important thing. there have been several kind of committees and campaigns focused on earlier diagnosis, and there was a researcher at the University of Utah, Lynn Brown, who had a paper who looked at this and found that, for probably about 1 in 5 patients, their diagnosis is delayed by about 2 years after their initial symptoms, and that the average time to diagnosis was just a little over a year. So it's clearly something that we probably can move that needle towards an earlier diagnosis. Before somebody is diagnosed with pulmonary hypertension, pulmonary arterial hypertension, they're oftentimes diagnosed with something else along the way. Sometimes that's asthma, sometimes that's emphysema, sometimes that's anxiety. There's a lot of different diagnoses that people pick up along the way that may not be the right ones as we're working towards pulmonary arterial hypertension. That said, at the end of the day, pulmonary arterial hypertension is still a rare disease. And so, I don't think that the right answer is to take everyone who comes into the emergency room with shortness of breath and work them up for pulmonary arterial hypertension. And the way that I tend to approach it is to say that, in medicine we have the phrase, take 2 aspirin and call me in the morning. And I've always felt like the most important part of that is, and call me in the morning. Pulmonary arterial hypertension is not a disease that comes and goes. And so if somebody comes in for shortness of breath and they get diagnosed with asthma, and that seems like a plausible diagnosis, that's fine. But if they get treated with albuterol, they get treated as asthma, and they keep getting worse, they don't get any better, then rather than continuing to say, oh, this patient has asthma, then that's the point where I really start to dive in and say, well, I think we need to reach down the list for pulmonary arterial hypertension, maybe start thinking about an echocardiogram. Certainly, if anybody comes in with a combination of shortness of breath and any signs or symptoms of heart failure, and by that I mean swelling in the legs, swelling in the abdomen, particular shortness of breath with exertion or lightheadedness with exertion, those are people who, that very first time, I would probably get an echocardiogram and start thinking about pulmonary hypertension. So next question we have on here is, what are patient-recorded outcomes and why are they important? There's a question on here about pulmonary stenosis as well as pulmonary hypertension. It's a pretty specific one, and so I'll probably hold off on that one for now. But thinking about patient-recorded outcomes and why are they important? So patient-reported outcomes. So there are lots of outcomes in medicine. There is your 6-minute walk test is an outcome. Your echocardiogram is an outcome. How many times you come into the hospital is an outcome. Ways of measuring how well something is working or how well somebody is doing. And in medicine, there has been a shift to say, you know what? There can be a lot of improvement in some of these outcomes, and maybe people aren't feeling any better. And maybe we're missing something, or rather not maybe, we certainly are missing something if we have improvement in all these other things and people say, you know what, I'm feeling better. And so patient-reported outcomes are a way of trying to figure that out. Now, it turns out that it's harder than you might imagine on a kind of a broader basis to construct questions that reliably say how people are feeling. And that's where this field of patient-reported outcomes has come up. Now, there are specific patient-reported outcomes for pulmonary hypertension, things like the emphasis 10 panel, 10 questions that you score, and gives you a composite score at the end to say, on the whole, are you feeling better? Are you feeling worse? Are you staying about the same? And these questions get tweaked and revised to make sure that if I take the survey in the morning and I take the survey in the afternoon and I take the survey next week, I'll probably get about the same score, meaning that it's not just a random number. And I think that it is important to think about how our interventions are helping with that. There are some things like exercise where patient-reported outcomes tend to go way up because most of the time people who get on a regular exercise routine feel a lot better. There are some of those other physiologic outcomes that improve as well, but oftentimes the patient-reported outcomes do even better. And so I think they're a very important part of the puzzle. It's what we do as doctors and patients all the time. And I use my stock phrase, are you feeling better, worse, or about the same? But patient reporting outcomes are a way of trying to quantify that and make it useful on a broader basis. Question here, should I be seen at a clinic that specializes in pulmonary hypertension? I would say that the answer to that question is yes, if you've got pulmonary arterial hypertension. Yes, if you've got chronic thromboembolic pulmonary hypertension. And yes, if you've got a type of pulmonary hypertension that people aren't sure what kind of pulmonary hypertension that it is. Now, does that mean that that's going to be your only doctor? That's something that is very different depending on where you are in the country. So here in the Northwest, the Pulmonary Arterial Hypertension or Pulmonary Hypertension Center at the University of Washington covers 5 states. So we've got Washington, Alaska, Wyoming, Montana, Idaho. And so it is quite common that we will be seeing patients at checkpoints in their disease, at diagnosis, when we start a new therapy. If people are feeling worse and we don't, the local team doesn't have a good idea for why. And I think that those are hugely important pieces to kind of be a part of. But because it is a long way from the Aleutian Islands to Seattle, it doesn't necessarily mean that we're going to be the person who sees somebody every couple months, or if they're not doing, if they're struggling with something every couple weeks. There are some places where there are enough pulmonary hypertension centers in a smaller geographic area where the pulmonary hypertension center kind of takes over a lot of the aspects of care. And so that's going to be different in kind of a regional setting. But I would say particularly if you fall into one of those groups, pulmonary arterial hypertension, chronic thromboembolic pulmonary hypertension, or pulmonary hypertension that people aren't quite sure which group it falls in, going to a center makes sense. Basically, most of the times that you're starting on pulmonary vasodilators, and that means phosphodiesterase 5 inhibitors, sildenafil or tadalafil, riociguat, endothelin receptor antagonists or prostacyclin analogs, those should probably have a center involved at some point. Can I talk about diet and best practices? In broad strokes, yes. So there are aspects of pulmonary hypertension diet that are analogous to the heart failure world. We've kind of talked about this already in a lot of ways. And that is a low salt, low fluid diet. And so, what is a low salt diet? What I typically tell people is a low salt diet means no added salt. So we say less than 2 grams a day is the target of what you're shooting for. A teaspoon of salt has 2,300 milligrams, 2.3 grams of salt. So a teaspoon of salt has already set you over your limit for the day. So it is learning to eat without adding salt at the table and cook without adding salt at the stove. And then beyond that, it is starting to be a label reader. Looking at all those labels of things that you're buying, particularly for processed foods, which oftentimes have a lot of sodium. Recognizing that a lot of the advertisement, things that say low sodium, things like that, can be a little misleading. Particularly, there's this reduced sodium. That just means that it has to have 75% less sodium than the original product. Most of the time, reduced sodium is probably still something that's on the not so good list for pulmonary hypertension, because if it was truly low sodium or sodium free, they would have said that. Reduced sodium typically doesn't get you there. So really focusing in on salt, trying to make sure that that is not a problem in your diet. Also trying to focus on that fluid restriction. The most important thing for fluid restriction, there are guidelines out there to try and ballpark it for you. We say 2 liters or 3 liters, which is kind of 8 cups or 12 cups. And so but the most important thing is that your weight is staying pretty steady every day. On hot days, you may need to drink a little bit more. And if your weight's staying a little bit steady, that's fine. If your weight is creeping up day by day, that means you're drinking too much. Those are the big things, and those are the things that we have evidence for. What are some of the other things that we tell people to think about with their diet? We tell them to think about making sure that they stay replete with their iron. A lot of people have implicated iron deficiency in pulmonary hypertension of its various forms. And so one thing that we tend to always check is what somebody's iron levels are doing. And the other thing that I would say is just eating a balanced, good diet. And if I knew all the clues to nutrition, I would be a millionaire, which I am not. But we, in general, kind of doing everything to moderation and kind of watching your weight and exercising are going to be good plans. Exercise is really an important thing when we're thinking about these lifestyle modifications. It not only helps people feel better, it may even modify the course of their disease. They're still kind of early in the course of figuring out some of these processes, but I'm a big believer in exercise and pulmonary hypertension. And listening to your body. You don't want to exercise so hard that you get lightheaded or dizzy. You don't want to exercise so hard that you take longer than 15 or 20 minutes to recover from that exercise. And so really kind of taking time to break a sweat and get tired and do those things is fine, as long as you're not pushing yourself too hard, and I think that can help a lot of people. So it does look like we're getting close to the end here. And so I might start to wrap it up. What's new on the horizon in pH and PAH therapies? Man, we could talk about this for like an hour. There are a lot of good things that are out there. I was just in China and Nanjing looking at a pulmonary artery denervation procedure where we go in, like we would with a right heart catheterization, and see whether or not we can damage the nerves out to the lungs, and which might cause the blood vessels out in the lungs to relax. There's a lot of new medications out there, things targeting inflammation, things targeting several other aspects that haven't been really kind of pursued before. I think that this continues to be a really vibrant area, and that we're going to keep working together as a team to make progress with. And so, I love this field because I love the patients and I love the energy and the enthusiasm and the idea that we're not sitting in place. We're better now than we were 5 years ago. We're better 5 years ago than we were 10 years ago. It is an impressive and fortunate place to be able to work alongside patients and other researchers. So that said, I'm getting high signs that we're probably wrapping up. And so what I want to do is just really thank everyone. The fact that you came here today really supports the idea that this is a vibrant community, that this is something that is important to all of us. And so continuing to work on that front. It's the end of pH Awareness Month, but let's go ahead and make it pH Awareness Year. And so continuing to work together to accomplish our common goals, I think is hugely important. And getting together to chat about things in pulmonary hypertension, find ways to be engaged, are all pieces of that puzzle. It's really a big honor that pH Aware asked me to kind of join you for this. Happy to do it anytime. And it is, I think, an impressive thing to be able to link this broader community together to continue to work towards a common purpose. And so I would just encourage everyone to keep doing what you're doing and keep fighting this disease.